The doctor doesn't know how to use the tool and misinterprets the tool. Even if they are the expert in that field, they may not know how to use this tool. They may not know what the tool can and cannot do. In that environment, even if the tool is perfect, the end user may not know how to use it correctly. We're all scared of what we don't know. But if we can educate patients and we can educate people on how to use these tools, then it's not as scary. Some patients out there that they don't feel comfortable talking to a human. They rather talk to a bot, have all that information told. To me, I would be fine with the patient telling everything to the bot, but then let me be the human in the loop. And then if there is a diagnosis, let me be the one that delivers it.
Healthcare is overloaded. More data, more tools, more pressure, yet outcomes aren't improving at the same pace. AI is being positioned as a fix, but the reality is most AI conversations happen far away from the bedside and far away from accountability. My guest today lives in those uncomfortable middle spaces. Harvey Castro is an ER physician, an MBA, a chief AI officer working in high risk environments like aerospace, and a global advisor to healthcare systems. He's not here to sell tools. He's here to talk about where AI actually works, where it breaks, and why human judgment still matters. Today, we're going to cut through the hype and talk about AI where mistakes aren't bugs, they're real consequences. Thank you, Harvey, for joining us today.
There we go. Thanks for having me. It's been a great journey. I want to start with saying back in the year 22, I was in this office literally playing on the computer, and ChatGPT popped up. Just by chance, it was the day it was launched. And immediately, within 5 minutes, I said, you know what? Let me write a book on how to use this thing and let's call it ChatGPT Healthcare. So that really was the beginning for me as far as how to leverage this technology. And the reason I wanted just to start off with that is just to show, there's some people out there that have come out and say they've been doing it, but I want to say, no, I actually saw it, created and created the book, and I'm actually working on the second edition right now for that book.
Wow, that's pretty innovative thinking. You actually bought the domain as well, if I'm correct,
Yeah, good
for
memory.
that.
So that was pretty cool. I was at CES hanging out with a buddy of mine. We were having lunch, and I was like, I have all these domains. I have ChatGPT Healthcare, I have this and that. And literally a couple hours later, OpenAI announced that they're launching ChatGPT Health, and I happen to own ChatGPTHealth.com. And so I thought, you know what, this is perfect timing because
Right.
everybody's talking about governance. Is this good? Is this bad? I'm like, you know what? I have the domain, so let me take advantage and teach AI in healthcare and how to use these tools correctly, not just ChatGPT, but all of them. But it just so happens that there's a lot of press going on with it. So I thought the timing was perfect.
Exactly. So I think, most people shaping AI healthcare have never actually practiced medicine and owned AI outcomes at scale. You've actually done both. So how does being an ER physician fundamentally change how you think about building and deploying AI compared to someone coming purely from tech?
Yeah, no, that's such a good question. At the end of the day, we don't know what we don't know. If you're really good at tech, you understand the programming, the data science, and you do it, you don't know medicine. And just because you may try to fix a problem and you have every good intent to do it, you don't know what you don't know. Putting on the doctor hat, I've been really blessed. I've had a really cool career. I've started over 20 emergency rooms. The biggest, I had my own healthcare system. I had my own hospital, urgent cares, billing, staffing, all that stuff. Grew to about 400 employees. So I was able to say I went through the ranks, being in the front lines for 20 years as an emergency room doctor, being a physician of a staffing company, being the physician of a billing company, being the CEO of a major healthcare company and hospital. I was able to put on those hats, and so I'm in this really weird, unique position that I could look at a tool and look at it as a physician and say, is this something the front lines would want? Is this something that patients would want? Because that's the other obvious thing. I see all these people programming, and I'm like, okay, in this committee, do we have a patient? And they all look at me like, no. And I'm like, that's kind of funny to me because I'm like, that's the main person. That is the main driver. And my point is this, it just gives me that advantage to look at it as a doctor, then look at it with the AI eyes. And then for a lot of people, like, well, what does this guy know about AI? Good point. What do I know? I wrote the book from my doctor's hat, really not knowing a lot of the AI data science behind it. And because I was in certain circles all the time with data scientists, I said, you know what? Let me go back to school. And I went through and got different certificates and really started doing well. And then I get to a point where I started becoming one of the professors at one of these AI healthcare courses. And it just shows that I was able to kind of continue to grow because I didn't know what I did not know from the data science side. And so to wrap this as a full circle, I was on stage giving a talk on how do we use AI in healthcare. And this is pretty cool. In the audience, we had the Ministry of Health for Singapore. And as soon as I came off the stage, they were like, everything you said on that stage, could you help the country of Singapore? And I'm like, yes, for sure. And so they said, okay, we want you to be one of our advisors. And one of the first meetings I had is to this exact point. They said, hey, Harvey, we want to create this legislation about AI in healthcare. And then I looked at it and I said, okay, give me a minute. I'm going to put my doctor hat. You're going to upset the doctors. We need to tweak it to this language and we need to make sure it does this. Then I said, let me put on my CEO of a hospital hat on and let me look at it from a ROI and the things that they're looking at it. And let's tweak this to make sure. And then they were looking at their own AI to create for the government. And I started looking under the hood and meeting with them. And I said, no, no, no. The way you guys are building this, you guys are going to spend so much money. It's not going to be worth it. So let me give you some ideas of a different infrastructure to be able to create it. And so that was a really cool example to show them how I was able to basically do the 360 and really implement, as opposed to having a whole team going through and explaining, going back and forth. We were able to just jump right in.
Interesting. And you kind of mentioned this, earlier when you were, sort of explaining your thought process behind this, in terms of how, having the patient in the middle is critical to thinking through the AI strategy, for which I think a lot of people are not really including in their approach. So keeping that in mind, what's the most dangerous thing you've seen happen when organizations try to remove humans from the decision loop too early, implementing AI?
Yeah, well, one of the first things that come to mind is the lack of implementation. Let's just say
Hmm.
company hospital says, "Oh, we're going to do this. We're not going to consult the front lines and we're just going to go for it."
Hmm.
It's interesting because if the culture, I think, is your rate limiting step in that if they're not buying in and you spend all these resources, time, and you go, "Here you go. Here's the product." And then the front lines is like, wait, we don't need help there. And then because they weren't consulted, the workflow is actually more work sometimes for the healthcare
Right.
professionals. So then instead of something being a tool to help them, it's actually a tool that the doctors are like, oh my God, this is making my life worse. This is not helping me at all. And then the adaption rate obviously is not going to be high. And then the hospital is stuck with, well, crap, what do we do? We signed this contract for X amount of years. We spend this money. We got to make this thing work. So that's quite interesting to see that. The other part of this is that's physician or healthcare provider facing. It's the patient side. On the patient side, maybe the doctors adapted, say, yeah, this is great, high five, the whole 9 yards, and then the patient looks at it and says, I don't want to use this, or I don't understand, or there may be some negative press, and they're like, how do I opt out of this thing, or do I go to another hospital?
Mm.
So go ahead. That's what I was going to say. I think at the end, I really, really believe it's the culture. We need more physicians, people like you that are out there explaining how these things work so that people understand. Because my other favorite phrase is we're all scared of what we don't know. But if we can educate patients and we can educate people on how to use these tools, then it's not as scary.
Interesting. And speaking of the data side of this, can you give me a moment from the ER days that you lived where a purely perfect data AI approach would completely fail?
We're completely perfect data. See, to me, that's really hard to find because unless that data was created in that particular environment, in that particular zip code, and it matches truly the population, it's hard for anything to be 100% perfect. There'll always
Mhm,
be that bias, or even if it doesn't have that bias, there'll be this slated towards X and Y. And so for having something, let's just pretend we did have the perfect data set and it was used. I think the example there I would see very possible as everything looks good, but then the end user, let's just call me out, the doctor, doesn't know how to
mhm,
use the tool and misinterprets the tool. And so
mhm,
that's why I really think, the buzzword is the human in the loop. But to me, it's not just any human. It's got to be the right doctor, but not the right doctor. The right doctor in that if it's a dermatology problem and it's a ER doctor, they may not know that part of medicine that well. And then the other part of it is even if they are the expert in that field, they may not know how to use this tool. They may not know what the tool can and cannot do. And so in that environment, even if the tool is perfect, the end user may not know how to use it correctly.
mm. So, in terms of proliferation of AI systems in the healthcare workspace, do you see this as like you keep repeating, more of an education problem or a systems or process problem?
Well, that's it to me it's like a continuum. If we're not educating the healthcare professionals on the good, the bad, and the unknown on the topic,
Hmm.
it's going to be really tough to create the environment for them to adopt the tool. If a good example is, I always say we should look at these algorithms like a food label, or if I prescribe a drug, whenever you go to the pharmacy, you get this big cover of all the things it can do. Plus, the pharmacist is supposed to sit down with you and go over the medication. And we don't really have that a lot of times in the hospital system. We're giving the tool, here you go, and they try to onboard you, but a lot of physicians and healthcare are really, really busy. And so they don't get that. And I feel like that's part of the problem for all of this. It's lack of knowledge. And then if you don't understand, then in general, healthcare is very conservative. And I don't see some parts of the world, or the US rather, parts of the US that will adopt this as quickly as other parts because of that culture.
Mm, interesting. So, in your perspective, who selecting from clinicians, administrators, regulators, or the patient themselves, who actually has to trust AI first for healthcare adoption to scale?
Yeah, that's a tough one. I think at the end of the day, everything's about the patient. So it needs to, um, you can go two ways. You can say from the CEO down, shoving it down to the patient, saying this is the way it goes, or you could go the other way, saying this is the patient, this is what they need, they fix the problem, and it goes back up and it gets approved. I think the easiest is if at the end of the day, we are about our patients. And to me, it makes sense to start at the patient because if the patient doesn't trust it, if the patient doesn't understand it, it's not going to happen. And eventually, um, that we've already hearing stories, like these chatbots that are helping you with depression, and then it hallucinates and it, tells the kid to shoot themselves, and it's like that makes no sense. As opposed to if we had an algorithm that was created at the patient level and then meticulously taken all the way to the market, and then that's where we're getting all this FDA regulation to make sure that these algorithms are correct and the data. But it's really interesting to me. I know I'm kind of going all over the place because it's a big topic, but I've met with the FDA and they're trying their best to approve as many as possible. But the problem with this data is that this algorithm changes literally all the time. And so, how do you
Mhm.
regulate something that keeps moving?
Hmm. It's trying to hit a moving target. Yeah, I mean, I totally understand. A lot of the technology is focused on a top-down approach, and a proponent of the bottom-up approach. And that's what gets missed out from most of these advances. Um, So I want to sort of pivot a little bit here because you obviously work in the aerospace AI as well as healthcare, both zero tolerance environments. It's just interesting. You just love stress, huh? What lessons from aerospace AI don't translate well to medicine, even though people assume they should?
Well, that's a good one. My problem is I see the glass half full, and I
Hmm.
feel that all of this is a certain science, and that science can be applied, and definitely in space. Um, for example, we are really blessed in that it's called phantom space. These guys are the number two and four to Elon Musk. They actually helped create SpaceX. And they, after one of the gentlemen, after 12 years, left SpaceX. He was the head engineer that created the rocket for Falcon and all that for Elon Musk. And fast forward, he created this company along with Jim Contrell, who is I call him like the godfather of satellites. And the reason I mention all this is they really took their time to think, how can we create something to help the world? And I know that sounds kind of odd, but let me explain. They have the launch pads. They're about by 27 they will have a functioning rocket. They're developing it. They're already selling satellites, and they've been working on putting data centers on their satellites. They have a patent for it, and so they have the full stack. Why does that even matter in healthcare? Well, and here's the question, and here's the translation. Obviously, I love AI in healthcare. I see a world pretty easily where you, the patient, needs to have an internet or have access, but you're on a plane, you may be on a mountain, you may be in driving from Austin to Dallas where there's a spot that might be dead that you may not get internet. What these gentlemen are creating is that full stack, meaning you will have internet. If your phone is not a smartphone, you'll be able to connect to the satellite, process that information because it has the AI on it, and then go back to you no matter where you are. That
Interesting.
loop would change humanity because of so many healthcare applications. And so to
Mm,
me, this translates pretty good.
interesting. And I know that you've been a really big proponent of human in the loop systems being non-negotiable in healthcare. Who do you think usually pays the price when that fails? Is it the clinician, the patient, or the system?
Good question. As of today, it is the physician because the AI that did not, you and I are in Texas, so the AI did not get approved by the state of Texas to practice medicine. And when
Hmm.
that day happens, it will be the AI. But until that day happens, it's going to be us physician. And the reason I say it that way is because we forget. Back in the day, I had a stethoscope. I ordered a CAT scan. I ordered blood work, and they weren't responsible for those things. At the end of the day, I went to school. I studied medicine. I got approved to be a physician. And so my point is this: at the end of the day, the physician is the one that looked at the data and said, "Yep" or "No."
Interesting. So let's kind of ground this discussion a little bit. In your experience, what's one AI implementation that you've seen in healthcare that looked brilliant in the boardroom? And I'm sure you've been to quite a few of them in that discussion, but it failed quietly in practice and kind of disappeared before it could lift off.
Yeah, well, that's a hard one because some of them failed because of price. So let's just talk ambient listening is the big one everybody's been talking about.
Mm,
So if my computer's over here on the left and I'm just typing away and I'm looking at you every other second, am I really even paying attention to you or not? But if I have that EMR that's linked to our discussion and it's putting everything in, then on paper that sounds great, no pun intended. But what if this is where it's an issue? What if the amount of money that the EMR for that feature is charging is too high, where the CEO has to decide, well, I can't keep my doors open because I have all of these other things to do, and this thing is pretty high cost. Maybe I should find something else. Or let's just say they went ahead and implemented it, but because that workflow that we just talked about, where maybe it's causing more work than it's supposed to because early on it wasn't transcribing correctly. Then the second part to this issue is the culture. There are some parts of the medical record that say everything's being transcribed, but there might be parts that the patient's like, wait, I didn't mean to say that. Or if the AI itself hallucinated and said, heard something else, and then that goes on the medical record. So, yes, it helps, but you got to make sure that it's a really good voice to text. And as you know, now they're pretty darn good. But earlier on, that was an issue.
So considering that you had experience in, sort of being on the forefront of tech in healthcare in two countries at this point, and I'm sure you've had experiences in other engagements as well that spread out. Do you feel that advancement in healthcare using AI um, could potentially be lagging behind because of policies that are
Oh, yeah,
applied?
for sure. For sure. In fact, one of my predictions, and I hate even calling them predictions, one of the things I foresee happening is we will see huge advances outside of the US before we see them here because of what you just said, because of the politics, because of the regulations. And then let's call it some of it is the culture.
Mm,
Some places are really worried that this technology is going to take their job. So, are they
mhm,
going to allow these tools to be used in their hospitals? No. And I'll just show you a radical other idea. I was recently speaking in Dubai, and they were talking about creating a digital twin, taking the country's genomes. They have one electronic medical record for the entire region. And I thought, man, these guys can create their own AI. They can create digital twins of their kids and take them through their entire lifespan to the point where, let me define it. Say we create a digital twin of you. What does that mean? Take all your genetics, take your way your body reacts, blood work, all the parts of you. I put it into a digital platform, and then say you have high blood pressure, and then I give your digital twin that medication to see how they would react, what side effects, what's the right dose, try different medications, and then by the time it's time for me to take care of you, I'm like, you know what? I tried 100 times all these different meds. This one right here at this dose should be the best dose for you, and they're doing
wow.
that for the entire country. Let's take it to the next level. They have their genetics. What does that
Mm,
mean? I'll give you a real example. Singapore, this is crazy. They have the
mm,
genetics of the entire population. I know some people are like, whoa, that's big brotherish, but just play along for just a second and say, what if? And not a what if, this is what they did with it. They're able to go back and look at all the patients that have familial hypercholesterolemia. Just think of it as really high cholesterol, but when you're born, the way your metabolism is, it just tends to have you with really high cholesterol at a youth age, where some of these people are having heart attacks in their teens. So, what the government did is they're using AI to identify who these children are because they have it. And now, through their AI, they're able to follow these kids, start them on medications earlier, start them on different exercise diets, and the whole idea is instead of them dying in their 20s, hopefully they will live way longer.
mm. That's that is not something that you would expect to happen here for sure. Um, so I mean, in your experience, what are some of the technologies that you see that are out there right now that are overhyped and ones that we should be watching out for that could potentially scale exponentially later on?
Man, that's a good one. See, on the overhype, again, I have a hard time with that, but I personally worry that some of these chatbots are overhyped in that, again, if they're trying to take the human out, and again, it's not just regular chatbots like you're trying to buy some groceries and it's helping you on the website or buy a plane ticket. This is more of a bot that's like walking you through a medication, or let's the one that I'm coming to think of is depression. To me, it's like a double-edged sword. There's some patients out there that they don't feel comfortable talking to a human. They rather talk to a bot, have all that information told, because it is kind of embarrassing for a patient to say, "Yeah, I drink a bottle of tequila every night." You know, like, They don't tell you that kind of stuff.
Hmm.
They're likely to tell the bot. So this is where this becomes like an interesting way of delivering medicine. To me, I would be fine with the patient telling everything to the bot as long as the patient knows that, hey, I'm going to be reading the transcript. If you don't feel comfortable telling me, that's fine. Tell the bot all of it. But then back to my earlier point, let me be the human in the loop. And then if there is a diagnosis, let me be the one that delivers it. Let me be the one that holds your hand. Let me be that human in that loop, but the right human, as opposed to the bot having that cold part saying, yeah, you have cancer and you will die in the
Hmm.
next 5.2 years. No, no. So to me, you could do the best of both. Let's leverage the AI. Let's look at the predictive analytics, but then let me be the head orchestrator of the whole team and saying, hey, this is how we're going to work this. This is the human now in the loop. This is my deductive reasoning, and this is how the AI got to this conclusion, but this is how I got to my conclusion, and this is why I think this is the best course.
Hmm. Interesting. Um, and to stay on that point a little bit more, and stress that and test that, so to speak. What worries you more right now? Is it the AI underperformance or human overtrust in AI?
Human overtrusting, because I'm gonna date myself. I went to med school back in the Google days, and people would show up with Dr. Google papers, and it was like a big deal because it was the first thing. My point is this: I got a lot of gray hairs, but it's got a lot of years of experience. So when the AI hallucinates, I can call BS on the AI and be like, "No, that is far from the truth. That's not gonna happen. That's incorrect."
Mm,
And I worry about the younger population. No disrespect to the new physicians because they're just learning, but that's my point. They don't have the clinical gestalt to say, you know what, this is correct or wrong. They don't have the wars, the scars from the war. They don't. And so when the AI tells them XYZ, they take it face value. And that really, really worries me because I know one day I'm going to be counting on them to give me the best healthcare, and I don't want to be 89 years old being the doctor still of my own healthcare.
interesting. Wow, that's a good pivot to my next question as well. So let's say, 5 years from now, um, looking out, we're not thinking about AGI yet. We're not hyping it up. What do you see as being the actual change inside hospitals because of AI? Is it staffing, diagnostics, or decision-making workflows that you see changing?
I think we'll see the bare bones of a hospital in the future. We're only going to see surgical centers, ICUs. A lot of the rest will be in your home. Will
And this
totally
is
shift.
5 years, or
Well, I see that moving towards the home. I see a lot of insurances, a lot of options pushing and pushing that that's going to happen. And we'll start seeing in 5 years a lot of the backbone of what used to go to the hospital be done, and you'll be doing it at home. Case in point, you need an ultrasound. I'm an advisor for Pons AI, and they have an ultrasound technology that you can put it at CBS. They can mail you a unit, and then you do your own ultrasound, and then it does predictive analytics to say what that disease looks like in 3 months, 6 months, or if it's someone that's doing a mammogram, to look for some abnormal tissue in their breast. This will highlight and show some precancerous cells that the radiologist could not see under non AI enhancement. And so that's a quick example how back in I see this in 5 years for sure. Some of these services that you would have normally gone to the hospital, you may just be going to CVS. Another example, um, dementia. It's a good one, or not dementia. The elderly. We this sounds really sci-fi-ish, but we will have a robot taking care of the elderly. And I know again that sounds cold, but let me walk you through it. The robot will be able to analyze let's say my grandma's voice and listen to her and say, you know what? We're detecting that you have prediabetes or that you have diabetes. Or, you normally sleep X amount and we're noticing that you are not acting right, or catching early UTIs, to the point where now the AI is literally hearing, seeing, and detecting different diseases. And so will my grandma end up at the hospital? Maybe not. She might have the robot call the doctor. The doctor shows up on virtual and say, "Yeah, let me start you on this medication." And depending on that person's status as far as finance, I don't see we're far away from a printer being in your home where it prints out your medicine. And so now you haven't really left their house. All of that stuff is here today. It's just a matter
Wow.
of scaling it.
This is starting to sound more and more like Black Mirror. So, from your experience, again, having that lens of sort of global exposure to AI, do you see us needing less guardrails or more when we're adopting AI in healthcare?
Uh,
And I'm talking globally, not just the US.
yeah, yeah. You know what's interesting? I know you mentioned AGI. I do think that in the next 5 years we will see a swap. We'll get to the point where we will, and it sounds like I'm going to talk on both sides of my mouth, but I'm not. But I foresee there'll be some parts of medicine that we're better off having the AI walk us through, especially when it's transparent. We can see how they got to the conclusion. It's serving the right population. There's, let's just call it, minimum bias. And the reason I say that is we will start seeing more and more um, globally applications in healthcare. Like the Utah one is a good one. Recently, Utah is allowing autonomous prescriptions of depression medications. There's no doctor in the loop. It's for low risk patients, and they pulled that off. And I'm shocked that they pulled that off in the U.S. So fast forward, more and more medicine is going to go that way.
Mm. The designer drugs and some of the other options that are going to become available. Yeah, obviously, with AI making things more accessible, cheaper, faster, niches will become possible then, right?
Yeah.
Um, so
Yeah,
from a
ask me that question
clinician,
again because I feel like I didn't answer your question. Sorry, I kind of pivoted. So, what was your
no,
question
it's
again?
okay.
Sorry.
So
Yeah.
my question was more in terms of guardrails. You kind of took a stab at it, but my question was whether we need more guardrails or less in healthcare when it comes to AI, globally speaking.
Well, here's the thing. If the AI messes up and picks the wrong stock, and yes, you lose money, no one really died.
Hmm.
In healthcare, if the AI messes up and someone dies, then are you willing to go more or less guardrails on something that it's so important? So to me, if anything, we need to make sure that the guardrails are there, but obviously we need to make sure that the data is correct. That
Hmm.
and that's where it gets a little hairy because if you look at historically what populations have been studied, who has the money, what diseases are being defined and who's paying for those diseases. Are they picking certain diseases that a lesser population gets or that they don't have as much funds? Or are we researching items that certain populations that have money are putting money into the system to grow and find a cure to that disease? And so if
Mm,
the data is biased in that it's doing certain highlighting certain populations, then the AI only is going to follow what it sees, and so it's
mm,
going to know those populations but not know the others. So then it,
mm.
it, it really becomes an issue.
Interesting. I don't think I even considered that aspect of this. Um, yeah, that's an interesting insight. So in terms of sort of I mean, one use case that you already mentioned was from a guardrails perspective is sort of the ER side of things, which is where you're coming from. But let's say preventative healthcare. There's been a huge push from wearables kind of becoming more and more commonplace now. Um, do you see guardrails that should possibly be removed at that stage to get a healthier population, or do you see that as it's fine the way it is?
I'm sorry, you broke up for 2 seconds. Say the question again one more time. Sorry.
Yeah, so my question was with regards to preventative healthcare.
Mm.
Do you see that section as over policed, or do you feel like it still needs more guardrails with the adoption of AI, especially wearables or things like that, essentially?
Yeah, I'm super biased with wearables in a good way, and I feel if my personal take is I'm happy to see a lot of these wellness programs out and the FDA kind of saying no, that's fine. With that said, the latest obviously with Whoop looking at the lawsuit with their hypertension, because then like,
Mhm.
well, it's a medical device, it's not supposed to be this. But I personally think preventive medicine is key. If you watch any of my TED Talks, I have five. One of them talks about let's move out of reactive medicine and let's move towards proactive medicine. And I think the
Mhm.
wearables is that way. I created a digital twin platform that I'm looking to put on the market later this year, and it has all my wearables, all my genetics, all my information, and it's really helping me pick what medications I should use, what how to change my workout, which exercises to do, what doses of my vitamins, and how to interpret the labs a little bit differently because it's looking at all of the data and going straight back to the wearables. Um, it's really cool because I have it set up where it'll look at how well I slept and my HRV and my heart rate and my blood sugar in the morning when I work. I wear a wearable, so I know what my sugars are. Not that I'm a diabetic, just because I'm a little OCD about data. And it literally will change my workout before starting. It'll say, "No, you didn't do X, Y, and Z. Yeah, we need you to do this instead." And then I have it fine tuned to the heart rate. So it'll say, you know what? Okay, fine. If you're gonna do this workout, we need you to stay within this heart rate to this heart rate range.
Right, right,
And
right.
so I'm getting amazing results.
So there is another subset of healthcare that's become very, very prominent, which is functional medicines. And you hear so many health gurus talk about it, and spreading perhaps a lot of misinformation as well. What's your take on that aspect? Sort of how if there's one source of truth for people, and if that's even needed, or you just, sort of trust in the AI and just follow a plan with ashwagandha or something, kind of curing everything.
Yeah, for me, that's why I'm really big on human on the loop. Yes, and that's where I get away with murder because I'm looking at my own data, having the AI look at it, and I'm like, yeah, this was not right, or this is correct, and I can tweak it. Obviously, the rest of the population can't, and so that the way I'm creating the platform is to make sure that we do have a physician in the loop, so that when the AI hallucinates or comes up with something left field, that the doctor ultimately is looking and saying, no, this is actually wrong, or let's tweak this to make it better. Um, but yeah, I'm really worried. I don't think today we are at that level. Are we going to be there in the near future? I see us getting closer and closer to a point where the AI is going to help us. And it eventually, the IQ of the AI will be so high that there'll be no human on Earth that can look at the AI and go through it and see if it was correct or not, because it's way beyond them.
Wow, that's a very interesting way of looking at it. So, if there's one idea you'd want healthcare leaders to walk away with from today's podcast, not about technology, but about responsibility, what would it be?
I think the one thing is if obviously you're going to look into AI, make sure you look under the hood and look at two things. One, look to see what that data set has and what it's has compared to your population to make sure there's some kind of a match. And then you're going to ask the person that's selling to you, take it with a grain of salt what they say because they're trying to sell to you. The second is if you do implement AI in your hospital system, make sure you have someone in your team that can look at it and evaluate it to make sure that it's still creating the output that you wanted. Meaning a lot of these AIs have something called data drift, and eventually it no longer does what you intended it to do. And so make sure you have someone in your team to be able to look at it and say, yeah, it's still functioning, or we need to change XYZ so that it continues.
Yeah, I think observability is definitely a key component that just does not get talked about as much. That distinction between capability and responsibility as well is something that industry definitely has to start having more conversations about. Thank you so much for joining us today in this podcast, and it was enlightening, a little bit scary, but definitely something that we can learn a lot from. Thank you for your time.
Thank you. Appreciate it.